Now you got hold of it here, and then set it. Then set it. Okay, does that make sense?
Yeah.
Okay, I'm gonna have you hop up. Don't run away. Come here, young lady. I want you to lay face down. So I want you to feel the difference. Okay, so most of the time, you guys, what I'll do is I'll do the same thing Tim does. I kind of work the traps, and you'll feel tightness in the traps, kind of lead you in a direction. Upper thoracics are pretty simple because they're thin up here. When I get down to the lumbars, I'll always either pull the shirt up, and she's got a real thin shirt. So, now you're fine, so I can feel, but hand contact is always better. It just kind of, it takes a lot of time if you're doing it on everybody. So I want you to see the difference. So when you make the contact, whether it's your inferior hand or superior hand, this ridge hand stuff, feel how that feels? Feel this one? Okay. Feel that? And that? See the difference? Okay. So it's patient comfort. You can move the bone and think, well, I moved the bone. They're never coming back because it sucked. It hurt. They didn't like it. So opposed to that, so when you got a curve here? You got an x-ray ever?
Yeah.
She feels like she has a thoracic curve right here. So I'm going to go to the top part of it, real gentle, and just set it. And when I adjusted it, I'm opening the facet with my hand and going right through the set.
So you're basically just doing a body drop, which you have
Uh-huh.
in this position.
Mm-hmm.
You're
Yeah.
not thrusting out.
No, body drop. Body drop, right there. Thrusting 200 times a day, you're exhausted. This makes your calves big. You're up on my toes. My table's a lot higher. My table, the top of my table is higher than where she is right now. And I have to get on my toes to adjust. So it's none of that. And it's just much more specific. But you're using your hands to feel. All the way, baby. You see the difference, how that felt?
Yeah,
Okay. What's important is use your pisiforms, feel with your pisiforms just like you do your fingertips. It's vital. You have to be able to sense where it is you're going and what it is you're doing. Okay? Questions about thoracics? I'm not going to spend a lot of time on them because they're fairly simple. But it's again, specific. What vertebra? Which bone? Which direction? Just that one. Make sure you're over it. Make sure you contact, and then set it. Yes, ma'am. Scoliosis. Okay, so when you got you know what? And that reminds me of something else too. I need to explain. Scoliosis and rib subluxations. Before I move on, scoliosis. Let's say we have a scoliosis to the right. And this is another reason why you take X-rays. Majority of the time on a lumbar scoliosis, it's like third lumbar has rotated. It's got the most amount of rotation. If you look at the spinous rotation, so if it's a third lumbar and it's rotated to the left, so the body is up higher on the right. I mean, it's just mechanics. I'm going to adjust on that side, the high side of the body. I'm putting motion in it. Because like I said in the very, very beginning, you're not going to straighten that spine. It's not going to happen. Most of the time, by the time they get to you, they're done growing. Now, if you get a 5-year-old with scoliosis and you can get them to come in at least 3 times a week for the next 10 years, you got a chance. And I've seen it. An adult with scoliosis, though, what you're hoping to do is restoring proper motion back in the spine of each one of those vertebrae so the scoliosis doesn't continue to get worse and you reduce that subluxation within the scoliosis. Does that make sense? But I'm always going to go to the apex of the curve, the apex of the middle of the curve, and that's what I'm going to adjust.
The convex side or the concave side?
On the high side. Convex side, on the convexity. Yes. Who's got a rib subluxation? Anybody got a rib? Come here, babe. Oh, you got a scoliosis? Okay, well, I'll use you for the rib. Come here, lay face down. Yeah, take it. So now here's the thing. The majority of the time, if you think about this, so let's say her curve, let's see. What side does your curve go? Oh, it's up here? Okay, I'm going to use this as an example. So if the curve goes this way, if it goes this way, the spinuses will go in toward the curve. They're not going to go out. They're going to go this way because the body will do this as it comes down, right? We all on the same page on that? Am I making sense? Does that make sense? So if you're looking at scoliosis, the spinuses are sitting to the left. You'll never see a spinous on the convex side going to the right. It'll always go to the left. As it curves this way, so as the spine goes this way, it does this. Does that make sense? I mean, it almost always does. So if it's doing this, the spinous is going to the left, your pedicle, you'll look at your pedicles over here. You'll see a pedicle on the right. You won't see one on the left because it's over here behind. So if that's the case and they're doing this, I'm contacting the body or the TV on the right, and I'm bringing it this way. I wouldn't want to adjust further rotation. I'm reducing the rotation. Yes? Yeah, okay. Yeah, I just want to make sure I'm saying it right. I'm not giving you a hard time. I'm making sure I'm not messing up my... Sometimes I see things in my head and the way I verbalize them are two different things, but... Okay, yeah, so she's got... And so, okay, this is good. So we can do the same thing. So right there. So she's got a rib there. And obviously in the thoracics, if the subluxation is this way or the rotation is this way, it's pulling that rib up with it. All right, the ribs are attached, so it's pushing them up. So what I'm going to do is I'm going to come through here through the rib, and the ribs run this direction. I'm going to pull that rib to me, pulling all that rib to me, right up under here. I'm pulling that rib right there. I'm going to pull it right to me. So where the rib articulates with the vertebra is where I'm going to adjust, okay? And my adjustment is straight through the facet, but you also have to think you've got a rib articulation. I'm only supporting over here. I'm only supporting right there. Just like that. Feel good? Yeah. So there was, but here's the thing. I didn't get in there and just mash her back, right? Pull the rib, take the stress off, because that rib's being stressed. Think about how much stress there's in there, that curve. So I'm pulling the rib to me. I'm hanging on. I'm coming right in my contact. I'm not backing off. And as I come through, bam, I'm setting that rib in place. Okay? Honestly, from what in my vision, what I see, they're back and lateral. They pull this way. They pull this way, because that's why I always bring them straight back in. And that's how I visualize it. Now, I see it that way. So I pull the rib in, and there's many times I'll take both hands, especially on a big guy. I'll take both hands, I'll pull it in, and I'll set it, and set that rib. Straight P to A. And on a rib subluxation, I go straight. I say P to A. I'm feeling it under. You know, I told you to feel, so you're feeling it. And there's a little bit of rotation in here. Yeah, it's P to A with a little bit of superiority. So I guess maybe it does go inferior. Down, yeah. Okay, I'll live, honey. I'm gonna beat on. I'm just using you and just beating on you. Okay.
You ever do the rib picking up on the hip? I know it's more of an osteopathic.
Oh yeah, doing that. You know what I do? He asked about. You guys ever seen that? Where you contact the rib and you pull the hip and you do that. I do that only time. I don't adjust that way. Again, because I had someone try to do that and they actually hurt me doing it. So I don't like it. But I actually have. I will do that a lot of times just to stretch, just to try to kind of relax them a little bit. Because if you guys in practice, if you had anybody come in with a real bad rib, you know what they're going to say. It hurts to take a deep breath. You know, you got one shot. You miss, they're done. And so, and I've had some really, really ugly ones come in that they turn into great patients because you fixed it. You don't, you've lost a patient, plus they're going to badmouth you for the rest of your life. So, any more questions on thoracics? Thoracic questions at all? Ribs? You guys, I mean, those are pretty much, everybody knows those kind of, yes, dear. The table that I designed has a, I'll show you guys, I'll have you pull up a picture. It has a slight, the foam is made with a slight hump right here. So when the patient lays on it, it does this. It opens up the thoracic piece, right? So it opens it up. So that opens up the facets, makes it a lot easier to adjust. It also has enough cushion so when they lay on it, even my pregnant patients can lay on it, and it gives enough. So when they lay on it, it's comfortable. It's not hard. And then when you make the adjustment, it gives just enough to where it opens, and then you can adjust. So in that case, if she was on my table, I don't know how they do over here in Scotland, but in America, our country is freaking ridiculous. Everybody is dying of something. It's amazing. Everybody has, like, old age is a disease. And everybody that comes in, well, doc, I've been diagnosed with osteoporosis, because they do a bone scan test so they can prescribe Fosamax. It's insane. So here's the thing. If you've got a patient that's older, I've got patients in their 90s. If they're older and they're osteoporotic, just adjust gentler. Just be easy. I mean, it's not hard. You just, again, you use your hands. This is why I don't like instrumentation adjusting, because there's no way of knowing what you just did. I can make an adjustment, and when you put your hands on a patient, Do it again. Lay on your tummy. So let's say she's 85 and she's got real bad scoliosis, and I have, and you guys, this is another reason. God, we sound like X-ray salesmen. How would you know? Everybody knows what a spondylolisthesis is, right? How would you know if your patient had one without an X-ray? You wouldn't. You absolutely wouldn't. So what you could be doing is you could be increasing that spondyloid, wouldn't you? So that, let's say L4 is anterior on L5, but they're really sore there, and you get in there and jam it. What'd you just do? You just increased their spondylo, opposed to coming to L5 and setting L5 back down on L4. Oh, thank you. I thought, good Lord. I thought I was going blind. I turned the lights on. So you have a patient where'd you go? With osteoporosis. So if they're really osteoporotic and they got all these things, and then you just come in, gentle, and you just adjust. Now here's the thing. You can adjust. I got patients in their 80s that I freaking moved their bones. Would they be diagnosed with osteoporosis? Yes. Now, if they're really brittle, I have one lady, that you're saying it, she has a hard time getting on the table. And I do a simple stretch. And as I'm doing that, she's moaning, she's hurting. And I just hold it. This is going to sound hokey. I'm going to let you get into my head a little bit. This is Tim Young giving his crazy secrets away. And I do this with a lot of patients. As I'm doing this and holding, I just keep telling myself over and over, I love you, I love you, I love you. And I do, and I love her. She's been a patient for years. I just tell her how much I love her. In my head, I don't say it out loud. Did you guys ever see that old, it's called Down the Rabbit Hole? What the Bleep, Down the Rabbit Hole, quantum physics. Did you guys ever see that? I watched it years ago, and this is what hit me. They did that study, the guy that did the physicist did the study where he took water, drops of water, and they thought awful things, death, destruction, hate. They said these things out loud. They said it, they did it, and they freeze-dried that water, and it looked like cancer cells. It was just distorted. And then they took the other one and they said out loud, I love you, beautiful music and all that, and it was a perfect crystal, like a snowflake. Your thoughts, and you guys know this, your thoughts will destroy you on the inside, but they also affect who's there. And so it's amazing what happens. And I just hold pressure, and I hold pressure because you can't do anything else at all. If you did, she would never come back. She's there every 2 weeks. She hasn't missed a visit in 2 weeks in 20 years. Her daughter, she can't drive anymore. Her daughters bring her, and her daughter will tell me this is the only thing that gets her through the day. Is she counts the days to come to your office, and all I'm doing, and that goes back to what Tim was talking about, technique. Now people say that you're not adjusting. No, but I am loving her, and that's what she wants more than anything else. So that's a long damn way of answering your question. If they got osteoporosis, be gentle, but adjust them, and if you just can't, give them who you are, and then they'll get better too. Okay, all the way, babe. Okay. Yes.
Quite a very nice way that osteoporotic
Okay.
women wear. I simply adjust my own fingers.
And that's wonderful.
And it's that you can.
Yeah, and what he's saying is fine. That's beautiful, because what you're doing is you're using your fingertips to be specific, but that's the same size. That bone right there and that bone is the same size. So if you can learn. If you get good with that, it's the same thing. But yeah, that's whatever it takes.
Just cushions the adjustments.
It just cushions it a little bit. Just be very, very gentle all the way up. Any more questions about thoracics? I say we just have so much time today. This normally we do this is like early in the morning till late at night because we get in the middle. But I'm going to condense it. So I want to get to lumbars and sacrum and that with you guys. We want to go ahead and move right on into it. Okay. Who has a real hard bad lumbar? You already talked to me about it. Come on, take your glasses off, honey. Again, the table that I've designed, it's the cushion enough to where I do a lot of prone lumbars. So let's say you have a L5 on the left. Come across and adjust, and I'll do that. I'm not going to do that on her, and I'll show you that. So let's palpate. So I'm going to show you the setup first. So I'm going to palpate, and she would have it on the right side. So we're all going to have to move around. So what I'm feeling. So she's got all these congenital things, and I would take an X-ray and I would see all that stuff. Here's the thing, wouldn't matter to me at all. There's never been a patient come to my office that I would not adjust. I've got patients that's got screws and plates in their neck, and I set that atlas just as big as day. I don't care. I got plates over here. I got congenital fusions. I just move it as one bone. L3, L4 is it fused? Sweet. I got less work to do. I'll adjust the whole bone. With her, what I'm feeling is her third lumbar. Right there, honey, isn't it? Okay, so she's got a third lumbar, and you can see, I can see, look at her pants pocket. See how far down it is compared to the other side? So she's high on the right side, that's third lumbar, but what I'm gonna do is, I'm gonna adjust L3 and I'm gonna adjust the SI on the left. This is, I mean, if she comes in my office, that's what I'm gonna do. I can just tell you that right now. So the first thing I'm gonna do is L3 on the right. I'm gonna show you guys that, so everybody's gonna have to come over here. This is a working class. I'm gonna pull your shirt up, babe. Okay, so, no, we're going third lumbar. So we're gonna do third lumbar. Here is two things. The setup is what drives me crazy about what most chiropractors do. And the other thing is they jam the facets. I'm not gonna jam the facet. Actually, it'll make more sense when I do this. Lay on your side, turn and face me, babe. Now, this is what I see a lot of, and I'm only gonna show you this in case you do this. I'm not gonna call you out individually. So if in case you do this, no one has to know. So most chiropractors lay them on their side, and they do this, and they put their hand on their shoulder, and they bring this leg up, and they do this. Has anybody seen this before? Everybody? Okay, wrong. This is awful. Do you like this? No, neither do your patients. They hate it. Hurts the shoulder. This is awful. No one likes that. And look at my shoulder. That's ridiculous. And when you're adjusting, they're jamming the facet. So let's change this. Let's pull off the shoulder. Hand on the elbow. That's more comfortable, isn't it? Right there alone, okay? She's not laying on her shoulder. I'm not gonna put my hand here. First of all, it's invasive to the females, and it hurts the shoulder. I'm just gonna hold right here. I've got you, okay? Straighten this leg, bend this one. And what I'm gonna do is, my thigh and her thigh is gonna reach. I'm not pushing her, I'm just holding her. And I'll tell my patients in the beginning, so they get them, you're gonna feel like you're falling, but I got you, I promise, okay? Come all the way over. Okay, now, look where the third lumbar, it's right there. It's not over here, it's right there. I've got control with my thigh. My knee is kind of hooked right here. So this is see that? Okay, so this is where I'm adjusting. I don't have to go crawling up on top of her, it's just right here, and this is comfortable. I can take my hands off, and I've got her, but I'm just gonna hold. Now, instead of cranking the lower back, third lumbar, I'm picking it up. I'm gonna pick the third lumbar up through the facet. Picture the facets in your mind, what they look like. Third lumbar facet. Piezoform contact. I'm coming in. As I come in, I'm moving tissue with my hand. Going right on it. Right there. That's all there is to the third lumbar adjustment. Now, if she's real tough like she is, because she's got all this spasm in here, if I need to get a little bit more tension or a little bit more, I'm going to come in like this. I'm going to more traction, and I'm using my hip and set it like that. Okay? Does that make sense? But most of the time, all you have to do is, and when I'm adjusting inferior superior, not P to A. Up the spine. If you get a real big, where's my little girls at? If you get a real tough patient, elbow. And I'll do that on somebody, I'll show you that. I'm getting ahead of myself. But right there, set it. You okay? It's not bad at all. It just moves. I'm not manipulating the lumbar spine. I'm adjusting the third lumbar right facet. Okay? Questions about that? You're not cranking here. It's there. Okay? Good? Okay. Now, so let's say you're going to do this. I want to show you guys. This is little things. Let's say you're in your office. So what I'm going to have her do is I'm going to have you lay on your back. See how I have a hold of her? Never let a patient go, ever. Hand here. Now, turn and face me this direction. And I hang on this way, okay? Switch hands right there. I never let go of my patients. I've always got them, and I don't care who it is. It could be a big old oil, we get a lot of oil workers that come in, or cowboys, or whatever. You take care of. This is how you build your practice, you guys. Okay, so straighten this leg, bring this one up. Now, she's got an SI joint, sacroiliac, that's dropped this way, so I'm going to bring it this way. Chiropractic is not really difficult. Bone width this way, let's go that way. I'm going to pick the whole SI up, okay? So this, and what you tell your patients, you got to let them know, especially you guys, okay, this is going to be a little weird. I have to come under the hip, okay? So when you start jamming your hand in their butt, and they're looking like, what the hell is wrong with you? So you come across. You know, this one, I've got to get a little different angle. So I'm going to put her knee kind of between here so I can come underneath. I'm coming under the sacrum, or under the ilium. The sacrum sits here, and I'll show you a sacrum adjust in a minute. The ilium, I'm coming under, right there. See how easy that is? We don't care about all the congenital stuff. All the way up. You're welcome. And then I always help them up. You guys see that?
Why did you take that inferior ilium contact again?
Because the ilium went this direction. It was sitting down.
Yeah.
So I turned on the side, and we're bringing it back up. Yeah. So it's went inferior. Who else has? Who has a lumbar or sacrum or ilium? Nobody? I figured everybody should have. Ask me questions along. I mean, interrupt me. Ask questions, you guys. I mean, this is your time. Face down. Because I adjusted the third lumbar on the right. I adjusted the third lumbar on the right, so I don't want to take the chance of aggravating what I just adjusted. You can, but what? And here's the thing too. Without X-rays, I'm kind of going off of gut. So when I felt the third lumbar on the right, I wanted to adjust it, and we got the hip sitting like this. It just made more sense to me, and my assessment and what I felt is to bring that ilium back up. That's why. Yeah. But a good question. I mean, here's the thing. I don't think it's wrong to try to bring this hip down. I just felt like this one needed to come up. That's the great thing about chiropractic, and it's a great thing, and it's a bad thing. Within the chiropractic world, we all understand, because we work with patients all day long. You get some medical jackass standing over here, he goes, well, where's the literature behind that? Stick the literature up your ass. I mean, you know, that literature never got a patient well ever. You know, I'm getting off of my tangent, I'm sorry. Okay, so lumbars. Okay, good. Big, no, good, not good for you, but big fifth lumbar on the right. I mean, it's like pushing on a piece of iron on this left side. So again, I'm going to come down here, L5, S1, right there. And if there's no doubt in my mind it's there. And if you really want your patient to holler, just keep digging on it. So, you guys want to feel that? Who wants to palpate it? I mean, just come right. What you do is you bring your thumbs right on either side of the spinous, and you feel the difference here and there. It's not hard to find, is it? Does anybody else want to palpate it? Y'all, go ahead. Let's see. Y'all trust me? See, when you get down in here, and get down to the fifth lumbar. You were up on fourth, third lumbar. Mm-hmm. Yeah. No, go ahead. No, this is why we're here. What time is it? Does anybody know?
20
Huh?
20 past 6.
Is it really?
Yeah.
Where'd our day go? Wow. Go ahead, honey. I got to. Yeah. I told you these days will fly. Okay. So there's two ways. You know, again, I would either do prone or I would do side posture. In my practice, I'm really getting better, and I've worked really hard through the years of getting good at prone. So, and I'm going to show you guys this, because if you have the right table, this works beautifully. Especially my girls. When you get these big guys that you can't put in side posture, this is where you go to. It's kind of a version of the Merrick. And you guys, most of you don't even know what Merrick is. Full spine specific is the very first technique ever. You ever watch the BJ video and how his hand here, it comes in here, and he does that? That's Merrick. And I still do that sometimes when I need to. But this is a version of it. So I'm going to take my piezoform, and I'm going to roll all the way across the spinous. And as I roll across the spinous, I'm feeling it. So my piezoform is dropping in to the crevice, for lack of a better word, in between the lateral process and the spinous. The divot right there, there's a name for it, whatever. There. That's where I'm going. So I'm taking my piezoform, and I'm supporting this hand. I'm going to come across, right into it. I'm picturing the fifth lumbar. Facets sit like this, right? So it only makes sense to set it just like that. And that moved perfectly, didn't it?
was the line of drive?
Pete A. On this one's Pete A. Okay, so that it moved. There's more. And I'm glad this happened. It moved, but if this was my patient, I wouldn't be done because there's a difference between cavitation and an adjustment. You can go and make a bunch of noise and think you did something. I promise you, I can go right in behind you and set that bone every time. Okay, so with this one, I got cavitation because he's got so much spasm here. When you get movement in there, it feels like the whole bone just broke under your hand. It freaks you out, and it still to me sometimes freaks me out. I go wiggle your toes, you know. So I'm gonna. So in the real world, he's my patient. Lay on your side, turn and face me. I'm gonna finish it. And a lot of times, I'll adjust a couple times side posture to get the bone starting to move, get the motion introduced because it's been so locked up for so long, and then I won't have to do that afterwards. Again, you're gonna feel like you're falling. Come all the way across. See, I have him here. See where I'm at? It's not painful to the patient. It's comfortable. The spine is right there. It's not way over there. I'm not having to crawl up on top of him. My elbow is in tight. I'm coming right into it. Now it moved. There was no doubt in my mind that time. And then all the way up. Perfect. How about that?
Your adjusting is a thing of beauty.
Thank you. I love hearing it.
What would you do? Mike's got no butt. If you had especially a woman who has a large derriere, where's your line of drive on that one, especially when you're doing a prone?
Now, that's a really good question because most of my girls, most of my women, I don't do prones on because of the, and this is, again, a lot of the stuff I'm teaching you guys is 20 years of me making stuff up in my head. This is the way I look at it. Their sacrums, the way their sacrums are made, it's hard to do a prone on a female patient. I've got some really, really big patients that I can pull it off with, but most of the time they're too little. They don't work. But if you have one, come here. You don't have a big butt, so yeah. I'm not saying that you have a big butt, but so let's just say that she did. So you've got a real big patient, okay? I'm gonna put them in side posture. Now, a lot of times what I'll do is I will get in between the hips and try to put motion there, and if it doesn't move, go ahead and lay on your side, babe, turn and face me. So so you have a big patient, and what you're gonna have to do, straighten this one, is stay right up against them because they really feel like they're gonna fall. As soon as you start doing that, they're gonna start grabbing for the table, they're gonna start jerking, and you just have to be careful. So what you're gonna do is when your line of drive, come over here, you almost have to use okay, I'm gonna be honest with you. This is where you're manipulating a little bit. You just are. I mean, it's either that or don't adjust them because you can't do it any other way. So their hips are real big. I'm gonna come up on top of their hips and I'm gonna use my thigh and I'm gonna set it like that. Oh, sorry, honey, I didn't mean to be mean to you. But I'm gonna use my hip and my back to say, she adjusted as soon as I put her in position, but I'm gonna move it like that. I'm gonna kickstart it. I'm sorry, babe. I don't mean to be mean to you. You adjusting? Perfect example. Okay. Take your glasses off. Okay. Nope. Oh yeah, actually I do. But see, and here's again, the reason that people put the head, because you're used to doing this probably in your practice, the reason how in the hell does this work? No. The reason you do that is because you're laying them on their shoulder. When you're laying on the shoulder, the head does this. And so you have to bring it up. You lay on your back, head goes back, you don't need it. Okay? My table, again, salesman, wish I had a picture. I'll show you a picture in a second. It's one flat bench. It's just one solid flat bench. You don't need moving parts. So, okay, so him, I'm proning him. I can promise you that right now. I can already tell. So what have you been adjusting on him? Which side? Or left, PL, posterior left? Okay. Okay, so the sacrum is really base posterior. It's posterior. So you got this L5 that's coming up with it. So what I'm going to do is I'm going to set the fifth lumbar on the left. I wouldn't even put him on his side. Okay, so this is perfect. So come over here. I want to show you this. Yeah. So what I'm going to do is I'm going to come to the right, and I'm getting way down in here. Okay, I'm going to really get tissue pull. I'm going to bring all that tissue pull down in there. Just like Tim was saying, get down in. I'm going to come across. Right there. and it moved beautifully. Now, with that being said, he still has that sacrum. So this is what I was showing you. So I'm going to go ahead and do it just to show you, okay? But that's how it adjusts it. Here's the deal too. You can come in here just like you're doing a thoracic, right here, and set it the same way. It already moved. But I have a lot of my big guys like this. I set just like that, and it just drops right in. So, but you're going to have, you guys, when you do this, commit. I mean, that fifth lumbar needs to be on the floor. You're setting the fifth lumbar, and you're planting it on the floor. Okay, now, go ahead and lay on your side and face me. I'm going to show you how you do the sacrum on him. Nope. Leave that down. Yeah. See, that's what. See, again, when you turn them like this, you don't have to raise that headrest piece. Okay. Now, this is perfect. Now I have a bunch of these guys. So you're going to have to control. Okay, you're going to have to control him. And this is what I was showing you. Okay, so again, a little bit of manipulation because it's just real hard to do this. All right. So I'm going to bring the leg over. I'm coming right in here. I got him. I'm contacting here. My left leg is holding him. My contact is my forearm. And my drive is I'm bringing this sacrum this way. Right there. On your back. And I'm moving it. Okay? Now, since we're doing this, drop your feet. Since we're doing this, and I'm just going through what I would do if this was my patient, sit the fifth lumbar. Try to move that. I do a hip distraction a lot. And here's what, picture this. You got your femur sitting up in the acetabulum, right? And so you got this whole thing going on. It's kind of like has anyone here ever set a dislocated shoulder? It's freaky as hell if you've ever done it. It sucks right back up in place. It's crazy. So picture this. If you open the femur head, you pull that open. It's going to be a vacuum. It's going to pull fluid into it, and it's going to take especially if you have real bad hips. You open that up. And you got to do it. You got to do it quick. You got to be fast with it. You open it, and it pulls fluid into the joint, and it allows more motion in the joint, which will take the stress off this area too. So does that make sense, kind of? Okay. So what I would do is I would come here, let the leg go loose, and you have to be quick, and right there, and it sets that acetabulum. Right there. It sets the acetabulum. I'm sorry. A knee? Yeah. We're going to do extreme. I did the hip there, but there's a knee adjustment that looks kind of like that, but it's totally different.
Yeah, but if I've got a knee problem as well, and we're trying to do the hip.
It won't bother the knee at all because the leg is straight, and when you open it, it's the whole leg is opening up. It won't bother the knee at all. Okay. No, well, it's it's a little external. What's that called? Pronation or supination? Right SI. Okay, so again, it all, and you guys, when you palpate or when you decide what you're going to adjust, I just am a firm believer. You're right. You're right. If you're paying attention, and what I mean by paying attention is shut everything off, let your hands tell you, and then don't second guess it, and just don't question. He has a right. He thinks it's SI, but I'm feeling sacrum, right there. That sacral base on the right side. So I'm going to adjust his sacrum on this side. So let's do that. So I'll show you guys. This is kind of the same thing I did a while ago. Lay on this side, turn it face me. Again, off the shoulder, hand on the elbow, okay? Just like with the cervicals and everything else. Freaking relax, man. Just take your time. I mean, I average a minute with a patient, and I'm taking my time. You learn to move fast without actually doing it. Most of the time, the reason it takes so long, and I had this conversation with somebody earlier, is because you're talking too damn much. You think about the conversation you have with a patient, I promise you 80% of it was useless. It meant nothing, it had nothing to do with their health. It was just filler because you want them to feel like they got their money's worth, or you're slow and bored or whatever. Any of my best friends come in, they're in and out in 30 seconds. They don't talk to me in the office. So we're here. Bring this up, across. Now, I'm going to adjust the sacrum on this side. My hand's coming under it right to the base of the sacrum. Okay? I didn't drop on him and twist. I adjusted the sacrum. Go good. No pain. Don't need to. Look. See if I raise the head crease now, his head's kinked up. It's comfortable.
It was actually very comfortable.
It's a lot. See, the only reason you raise it, now if I was to do this, okay, see the difference? Okay, that doesn't feel good at all. But if you do this, off the shoulder, then you got people with bad shoulders. See, in America, and I don't know how it is here, but everybody works on a damn computer. See, this is what I'm seeing. It's this, and this, and this stuff. It's kick stuff. No one likes that. Nobody likes that. This is a piece of cake. It's just easy. In a second. I learned this with big patients that you just can't contact them, or they're really, really hard to adjust. So then I'll come around and I'll get right here on top. So you're right here like this, come across here. See where I'm at? My arm is in tight. You can feel how much force is being generated there. Doesn't hurt me. There. And then you're using your leg at the same time. But you can still be pretty specific with it. There. All the way up. A quick little story. I'm bad about telling stories, but I'll tell this story. I told you I tore bicep tendon from the bone, and I had surgery on it, and so I had it in a splint, and I couldn't use it. And a patient come in, and I learned to hook my elbow under and adjust with one hand. And I would get here, and I would adjust with one hand. I just adjust everything with one hand. I did that for like 8 weeks. And one of my patients come in. You guys know what Shriners are? You know the old shrine moss, you guys have those over here? They're crazy. They're batshit crazy people. They're the ones that wear the hats and they drive the little cars around and get drunk, but they raise a lot of money, like the Shriners Hospital and stuff. Anyway, he was a Shriner, and he was a retired truck driver, and he wore a wife beater, you know, the T-shirts, that's what we call them in the States, big gut, and he'd walk in, his name was JR, he'd walk in my office, and it was packed, and he would stand there like that in the middle of the waiting room, and he'd just go, quack, 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 where's the quack? He'd just stand there like this. And we're like, who the hell is this? And he called me quack, but he was there all the damn time. So he came in, and I adjusted him with one arm while he leaves, and he doesn't say a word. About 2 months later, he comes back in with his wife, Millie, and Millie sits over there, and I said, I've been adjusting him since the 90s. And he said, I want a real adjustment, not that one arm crap that you did last time. He said, that wasn't worth a damn. All right, JR. So he laid face down, and I looked at Millie, and I winked at her, and I put one hand in my pocket, and I adjusted him. And I set him, and he goes, that's what I'm talking about. And went and sat down. All in your head. I learned to adjust. And then what's happened, a year later, I tore this one. I had to do it all with my left hand for 6-7 weeks. God was teaching me some lessons. I can adjust the wrist with one hand. I didn't even know I could do it until you have to. The reason I tell you that story is that you focus your energy, find a way. You find a way. But here's the thing. Yeah, you can do every adjustment prone. You can do cervicals prone, thoracic prone. But here's the thing. And it just won't apply to you guys, and I have to talk about this a lot. There's a group in Oklahoma, it's based out of Oklahoma, in the country that really teach this prone technique, but it's like, and they just barely touch you. I call horse shit on all that, man. You have got to move the bone in my world, and I know there's these non-force techniques and all this stuff, but whatever. It wasn't non-force that run into you from behind at 60 miles an hour. It wasn't non-force that you fell down a flight of stairs. It's non-force that gets you in this, non-force doesn't put you in a subluxated position, right? Well, why is it that you have to have all this force, and we talk about, if you study philosophy and the 33 principles and force and how the body adapts to force that got you subluxated, then why is it that you don't, it seems to me that you need the force to unsubluxate. This touching stuff, I just don't buy, whatever. But if you're going to do prone, you got to learn, you got to practice and practice and practice to move that bone. You got to have motion, because what did I say in the beginning? We're restoring proper motion back into the joint and allowing innate to then to correct itself. Without proper motion, it's not going to work. Okay? Any more questions about lumbars, sacrum?
You were just in the prone adjustments higher up.
I'm sorry?
You were just in prone lumbars.
Yeah, and that's a really good question. Who haven't I adjusted yet? Come here, babe. Let me show you something. Now I'm glad you brought that up, because this is really important too. Face down. How does that thing work? Oh, here it is. Okay. So, very important. And you got, again, I'm probably preaching to the choir. Most of you guys probably already know this. You've got, as you come off the lumbars here, third lumbar, you start coming up to the transitional segments. between T12 and like L2, this is the most delicate, gentle place that you want to be. Your kidneys are right here. All I have to do is that, and she already jumped. She already guarding. You guys know that. All you have to do is just, look at that. As soon as I push like that, she's jumping. Your body's going to try to protect that. Do not slam into this area. It is the biggest mistake chiropractors make. And I have them do it to me all the damn time because my paraspinal is real tight and they get in there and just jam. So what I'll do with, on prone here, I'd stretch first and just take the tension off of it. And a lot of times what this is telling this patient is that I'm not going to be mean to you. I'm going to be gentle right here. And then I'll come in real slow, real easy, and just work through that muscle. Let that muscle relax, and then set it. And then set it. But most of the time, if I get real guarded here, then I'll do side posture. But you can still do it. You just have to be very careful. You still have to move it, but you got to be very careful with it. I'm gonna go ahead and work on you. You got a rib right here. It's huge. There we go. Okay, she has, chiropractors are all jacked up. So we're going to come across. This is a T3. I'm coming across. I'm setting it. Just all that. That's all we're doing. Sore as a boil in it. Third lumbar. Okay, so lay on your right and face me. I want to show you guys third lumbar. And then what we'll do is after I adjust her, we'll work on some extremities if you guys want to, and then we'll adjust everybody since we're kind of running close. So third lumbar. You guys see that? It's easy, isn't it? But you notice, here's the difference. I didn't fall on her. I didn't jam it. I came up and opened the facet. Third lumbar facet, right? Okay, on your back, honey. Have I adjusted your cervicals yet?
T1.
Huh?
T1 on the left.
I did T1 on the left. Okay, we got a C2 over here. Okay, guys, remember? Second cervical. Right there. Yes. Very good. Good. You okay?
Yep.
All right. I'm used to always grabbing my patients when they sit up because most of the time they're doing this number, so you always hang on to them. So since you're sitting there, who had the shoulder issue? This one here, and you guys. Okay, come over here. So there are different shoulder adjustments. We're just going to work right on into it. Two of them that I do. This one be very, very careful with. You learn how to. So what we're doing is the shoulder joint is made up of the clavicle and the scapula, the AC joint, right? Humerus sits up in it. Most of the time, what happens is the shoulder blade, the scapula, will laterally deviate. It goes this direction. So we're going, and I'll show you that here in a second. We're going to bring it around. But what I do see a lot, and I really think it's a lot because of this stuff here. Hold your arm up. Don't. I'm going to push down. So it's this gravity all day long, putting pressure, and you have patients they say it hurt right in here. So it's putting a lot of stress on this AC joint. So it's real gentle. I'll come up underneath, grab the elbow, come this way. Make sure that the hand is loose, and you're going to come right underneath and just fall toward me. Let it bounce. Now sometimes they're real guarded like she is, so I'm going to say do a shoulder shrug, shrug real high, now drop it. Shrug again, now drop it. There it goes. Okay, so we're setting that AC joint. Okay, but be careful with that. If you do it too hard, you can really hurt them in there. You got to. It's feel. It's like I'm feeling that tension in there. So let's do this one. There you go. I got you. What I'm doing is I'm taking it through with range of motion in here, and I'm feeling where it needs to be. And if you do it enough and pay attention enough, you can figure that out. Okay, now stand up for me. So here's the other one. Face you goes this way. Okay, so scapulas. The scapula will laterally deviate. So here's the scapula. Okay, and what happens is if you look at the anatomy of the scapula, right up here on top is called what? Coracoid process. Okay, so it sits up here, and it's what attaches to the clavicle. So what happens is if the shoulder blade laterally deviates for laying on your, sleeping on the shoulder or whatever, it'll do this. That coracoid process, obviously, it's going to go forward. So then, if it's here forward, if she raises her arm, it's digging into that shoulder. That's going to cause a lot of inflammation. So what we're going to do is we're going to bring the scapula back to midline. So what you want to picture is, everybody knows what a mason jar is? I'm from Oklahoma, so I'm going to make sure I'm using a jar with a lid on it. Okay, so what we're going to do on the right side, we're going to tighten the jar. On the left side, we're going to loosen it. Just going toward the middle. I'm hooking the wing of the scapula with my pisiform. I'm holding the whole shoulder like this. Right hand goes on the shoulder here. Reach under, grab the elbow. Be very careful with your girls. When you come around, make sure you're grabbing the elbow. Just word to the wise, I've never have I missed. Relax here. Have them turn her head to the left. Spread your feet just a little bit. Okay, so she's going to turn her head to the left. So as we come up, you're not jamming her face. Scapula or pisiform comes into here, and I'm opening it this way. I'm going to have her fall toward me and set it right there, this way. If it's the other direction, here, let this arm fall. I'm reaching into here, turn your head to the right. I'm coming around this way, fall toward me, and set it, just like that. And so if you do this and you practice it, there are many times I'll do this, and then I hang on, because they'll collapse. They'll drop. I mean, there's been so much pressure. When that falls, they're just, and you got to hang on to them. I've been doing it a lot sitting down, like seated, but I wanted for standing to show you. You feel that move big, didn't you? And that was the shoulder that needed it too. So, who is my other shoulder guy? Yeah, come over here. Here, sit on the other side. Which shoulder is giving you a hard time? Left side. Okay. So, what nerve innervates the shoulder? See, you're on my A list. Fifth cervical. What's it called? It's the axillary nerve. Axillary nerve branches off the C5. So if we've got a shoulder condition, have I adjusted you yet in cervicals? Okay, so the first thing I'm going to do is check C5. I'm also going to check for shoulders, first thoracic rib, right? First rib, because what runs right behind that rib? Brachial plexus. Brachial plexus can innervates the shoulder. Okay, so you want to check this, you want to check that. So C5, we're going to check this, then we're going to check the shoulder. So if I've got a bad shoulder, we're checking everything. Not going to go just, you're not being narrow-minded, so lay on your back. So I'm going to check his fifth cervical first. Okay, there's that. Hang on a second, stay right down there for a minute. I'm sorry, getting ahead of myself. Fifth cervical, we're checking. No. First rib, take your thumb right off this collarbone, right down in there, and you'll feel it. And he doesn't have one. If you did, I push like that, you're going to know, and he's going to know. It doesn't feel good at all. So we adjust that. Spread your feet. Okay, this hand on this shoulder. Rest this arm. I got you. Turn your head to the right. There it goes. Feel that move? Yeah. How beautiful is that? Very good. These things you're not going to learn today. I want to introduce you to them and show them to you. But the mechanics, it's all mechanics about how it works. If the bone goes this way, put it this way. But it's intentional, it's specific, it's not back, and it's setting the bone. Very good. Okay, that's shoulders.
Was that, you took that one clockwise?
I took the left side counterclockwise because you're going back toward the body. The first rib was kind of like a first thoracic adjustment. You get, and it's hard. The first rib is probably one of the hardest. Is anybody I can just like be mean as hell to? Yeah. I love it. You're great, man. You're just a guinea pig. Lay on your back. First ribs are awful. If you ever get one, you'll never forget. And there's a lot of patients that are getting that brachial plexus surgery, thoracic outlet syndrome. It's ridiculous. All it is a first rib subluxation. Is all it really is. And what they do is they go in and cut the first rib out. Yeah, it's beautiful. Probably they make more money than I do, so whatever. Okay. Feel this compared to this. Feel how tight that is right there. His is not bad, but it's there. He actually has one. So I'm going to come. You got to picture the first rib. And I'm adjusting it in the anterior articulation. Okay? Posterior, I would adjust T1. If I'm going to adjust it, I'll adjust T1. And if you adjust the first thoracic, that's going to help the T1 posterior articulation, right? Because they're connected. But if you're going to adjust an anterior T1 rib, you got to come. It's compressed because it's doing this. So I'm going to open it up. So my thumb is coming in behind the rib head, and my fingers under here are behind it, and I'm setting it right through there.
Pushing it down and in.
Yeah, yes. I'm trying to picture in my head how to say it out loud. You all right? Yeah, that was big. You got to get in front of the clavicle. You got to drop down. You got to drop down. You got to drop down. You're actually dropping in behind the clavicle. You're dropping behind the clavicle into the first rib and setting it up underneath there.
Did you just laterally flex him to the?
I laterally flexed him. I laterally come across the right-hand side so I could get the muscle tension out. Yes.
You lay his head back.
Now here, lay on your back. I won't do it. I'll just show you. So, I did this. I come. Here's the call. Here's. I did this to get my thumb in, and I contacted, and then I went there. Okay. Yeah. Okay. Good. Good question.